Good afternoon. I'm Liz Goldstein, Executive Director of the Anticoagulation Forum. I hope everyone is staying warm and safe in this crazy winter weather around the country. Thank you so much for taking the time to join us. We have over 1,000 people logging in today. Today we'll be discussing a new rapid resource from the AC Forum, Peripheral Artery Disease and Dual Inhibition Therapy. We have created 12 of these one-page quick clinical guides, and I hope you will find them useful. Please visit our Centers of Excellence at excellence.acforum.org to access the additional topics. There is a link to this rapid resource in the chat. Next slide, Henry, please. This webinar is accredited for physicians, nurses, and pharmacists. Please visit AC Forum's website or the direct link on this slide to claim your credit. The slides will be also in on the website, and the link will be in the chat box to claim your credit. Next slide, please. I am thrilled to have all 5 authors of this rapid resource on the webinar today. Dr. Geoffrey Barnes is a cardiologist and vascular medicine specialist at Michigan Medicine, co-director of the Michigan Anticoagulation Quality Improvement Initiative, or MACI2, and an active AC Forum board member. Dr. Marc Bonaca is also a cardiologist and vascular medicine specialist and has run many multi-center randomized clinical trials. His key areas of interest include patients with PAD, polyvascular disease, and diabetes. You know, the easy patients. Dr. Henry Hahn is one of our very first Anticoagulation Forum and Cell Vascular Medicine Fellows training at the University of Michigan, and we are very excited to have him participate in this project. Dr. Bishoy Ragheb is a pharmacist and the Anticoagulation Program Manager with Tennessee Valley Health System's VA Medical Hospital. Bishoy is the chair of the AC Forum Center of Excellence Committee and is the author of the famous bi-weekly literature update. This is an incredible resource for staying up to date on important publications in this space, and we'll add a link to this in the chat. And last but not least, Eva Kline-Rogers is a cardiovascular nurse practitioner and co-directs the Michigan Cardiovascular Outcomes Research and Reporting Program at the University of Michigan. She is active in the MACI Quality Improvement Group with Jeff and has been on the board of the AC Forum for almost 6 years. Thank you all for being here to teach us today. We are so grateful for your time. Next slide, please. Here are our financial disclosures. This project was sponsored by Janssen, but all content was developed independently by the Anticoagulation Forum, and the funder had no input in the content of the rapid resource or this webinar. As always, please feel free to ask questions during the presentation using the Q&A box. Thank you again to our speakers and to everyone joining us today. And I'd like to now introduce Dr. Henry Hahn.
Thanks so much for that wonderful introduction, Liz. I want to start this webinar by giving a little bit of background on PAD. Lower extremity PAD in particular is what we'll be talking about today. Discuss a bit of the epidemiology, symptoms, and prevalence. And so we'll start with the graph on the left-hand side. These are some data from the NHANES registry, which has been collected for many, many, many years. This is from the American Heart Association most recent 2020 update. And there's 2 points that I want to make with regards to this graph. So moving left to right, you'll notice increasing age by decades. The different colored bars represent different ethnicities. And you can see when you're getting into the 6th decade, you're starting to see increased prevalence in PAD across all different ethnicities. As you get into the 7th and 8th decades of life, you see a pretty rapid increase in much higher prevalence with, again, across all ethnicities. Strikingly, at 80 years or older, the prevalence amongst all groups is higher than 20%, and then all the way up to nearly 60%. I will mention this graph is representation of data in men, although the graph for women follows a very similar distribution. The second point we'd like to make using this graph is you'll notice that these red bars are disproportionately higher, and these red bars represent a patient population group of African Americans and Black patients. And so you'll notice, again, starting from the 6th decade into the 7th and 8th decade, there is more than a twofold higher prevalence within this patient population. And so something that we should certainly be cognizant of, since this appears to disproportionately affect African-American and Black patients. Moving on to the right-hand side graphic, we've known for many years and a very long time that smoking is a very important risk factor for peripheral artery disease. This was a study by Ding et al. From a couple years ago now, and they looked into how smoking affects your risk for different forms of atherosclerotic disease. And so we'll start with this top graph, which you'll notice that for people who have smoked more than 25 pack years, upwards of greater than 40 pack years, you have a 4-fold risk of having PAD. And by comparison, for coronary disease or coronary artery disease and cerebrovascular disease or strokes, with that amount of smoking 25 to 40 pack years or more, you do have increased risk, although this is only increased to 2 times as high as compared to the 4 times higher risk seen in PAD. Similarly, we know that diabetes, hypertension, and hypercholesterolemia are comorbid with PAD. These are some data, again, that represent the longer standing patients that have diabetes and hypertension. You do get upwards of a 4-fold increased risk of having PAD. This is also seen in hypertension, and for high cholesterol, this is a 2-fold increased risk. I want to bring this again back into focus in terms of health disparities. As we had seen from the first graph, this is a disease that seems to disproportionately affect older people, and in particular Black or African-American patients. And so this was a study from 2018 by Arya et al. They actually were interested in not just how race affects the risk of amputation, as you can see on the y-axis, but socioeconomic factors using an annual household income of $40,000 as well. You'll notice that these 2 lines that are represented by black and red are the Black or African-American patients, and then the blue and green lines are represented by white patients. Over time, which is the x-axis, you can see that at every single time point, there is a much higher risk, almost more than 2-fold risk of amputation amongst Black or African-American patients as compared to white patients. And this holds true regardless of socioeconomic status, whether they made more than $40,000 as household income or less than $40,000. So certainly something that we really need to stay cognizant about, since this is an at-risk population. I wanted to talk about the overlap of atherosclerotic disease as well. Certainly, as we know, atherosclerotic disease doesn't always necessarily have predilection to depositing in any one vascular bed. So I want to focus on this red circle here with peripheral artery disease. You'll notice that from these overlapping sections with coronary artery disease and cerebrovascular disease, it ends up accounting for 61% of PAD patients that, in addition to PAD, either have CAD and or cerebrovascular disease as well. And these are some data taken from the REACH registry from Bott et al. So quickly going through clinical presentation, before we even get to claudication, certainly you can have asymptomatic PAD. This is usually diagnosed using vascular lab studies, such as with ankle brachial index and occasionally with other imaging modalities, such as CT angio. After asymptomatic disease, we typically see intermittent claudication in patients with low extremity PAD. And this is described as an aching or burning sensation in leg muscles. Sometimes patients will also describe a cramping sensation within their buttock, thigh, or calf. These symptoms are reliably reproduced at a set distance of walking. So for example, a patient will tell me, "Doc, every time I walk from my front door down my driveway to my mailbox, I can almost guarantee that I'll have onset of symptoms." And then another feature of intermittent claudication is that these patients will say, "After I rest for 90 seconds or 2 minutes, the pain or discomfort will go away and I'll be able to walk a similar amount of distance before the symptoms come back. One of the distinguishing features of intermittent claudication from critical limb ischemia, as we see here, is that you should never have symptoms present at rest. And then another feature we mentioned is that it should not be exacerbated by position, and this helps distinguish it from other forms of claudication, such as neurogenic claudication, which can come from reasons such as spinal stenosis and things like that. Talking about critical limb ischemia, you do need to have one or more of three features, and those are ulceration, gangrene, and rest pain in the foot for more than 2 weeks. These are features that characterize and separate critical limb ischemia from intermittent claudication. And as things get worse, we do get into the acute limb-threatening ischemia section, which classically does present with very sudden onset of symptoms and can be sudden deterioration from one of these other previous clinical stages. The 6 Ps we look for with regards to acute limb-threatening ischemia are pain at rest, pallor, pulselessness, paresthesias, paralysis, and then a perishingly cold limb on palpation. So I also wanted to include this slide to give a bit of a mechanistic explanation for why we are talking about rivaroxaban and aspirin dual pathway inhibition therapy. In 2018, there was a study by Narula et al. Where they actually looked at the histopathology of the arteries of patients that had critical limb ischemia. In almost 240 patients, what they found after looking at the artery sections underneath a microscope was that in 73% of these patients, they did, yes, have presence of atherosclerotic disease, typically related to cholesterol and hyperlipidemia. But in addition, these 73% of tissue sections that they looked at also had thrombi within them, and only 25% of their tissue sections only had the atherosclerotic narrowing or stenosis. You can, this is something that we can think about similarly to dual antiplatelet therapy, where you try to use 2 different medications with different mechanisms for inhibiting different pathways. And so this diagram here, represented here, is a diagram of a platelet with all of the surface receptors and all of the different molecular compounds that activate these surface receptors. I've highlighted here 2 of them, thromboxane and thrombin, which are inhibited, the thrombin by rivaroxaban, a factor 10A inhibitor. And then this is downstream of cyclooxygenase, which is inhibited by aspirin. So this is sort of the mechanistic explanation for why the studies initially thought to try aspirin and rivaroxaban. So I'll turn it over to my colleague Eva for a case presentation here.
Great. Thank you so much, Henry. So we're going to use a couple of case presentations today to illustrate some of the concepts behind treatment for PAD. So case number 1 is a 67-year-old woman with critical limb ischemia secondary to progressive PAD, who undergoes endovascular intervention. In this case, it's balloon angioplasty and stenting on an infrainguinal lesion a few days ago. So high-risk lesion, recent. Her other medical history includes diabetes and significant carotid stenosis. Prior to admission, she was taking aspirin only. Now, post-procedure, is taking both low-dose aspirin and clopidogrel, 75 milligrams, and this is planned for the next 3 months. Would this patient benefit from dual inhibition pathway therapy? And I'm going to ask our panelist, Marc Bonaca, to answer this question.
Yeah, well, thank you. I really appreciate the opportunity to discuss this. This patient that you're talking about, really, when we answer this question, there are 2 questions. One is, what's her risk profile, early and late? And then, will this be modifiable with dual pathway inhibition? When I see her, there's 2 things. One, she's 67 and she has polyvascular disease. She has both peripheral artery disease and carotid disease. She also has diabetes, and we know that these work synergistically in terms of risk. Now, she is at the most vulnerable point in her risk profile. She's having a revascularization procedure. We know these patients are exquisitely high risk of acute limb ischemia and amputation. And then when you layer on top of that her presenting syndrome of critical limb ischemia, she's the type of patient I would expect to have somewhere between a 25 and 30% risk of a major adverse event of the limb, heart, or brain over the next 2 to 3 years, probably within the next year. And so there's clearly risk. And I do think this risk is modifiable with dual pathway inhibition. So on the current slide, you can see the rapid resource, and let's just zoom into what the guidelines would say about a patient like this. Here to orient you to the table, on the left, we have the AHA-ACC guidelines. On the right, the ESC guidelines. There's a lot of consistency here. And what you'll first note is that really the only class 1 guidelines are not in the post-procedural setting. They don't apply to this patient. They're really for antiplatelet monotherapy for secondary prevention of major adverse cardiovascular events, not limb events. Now, we've heard that this patient may be discharged on dual antiplatelet therapy with aspirin and clopidogrel. We can see that gets sort of a 2A or 2B with a class C for evidence, because there's no randomized trial to actually show that there's any benefit in the limbs, but we sort of extrapolate from the coronaries, and we know this is a high-risk patient. And then you can see for oral anticoagulants, there are differing levels of evidence. You can see that in the European guidelines, there are some data for, or there's a recommendation for vein graft. And then you can see for endo, you might do oral anticoagulation. Now, the one thing I want to say here is that oral anticoagulation is different than dual pathway. Oral anticoagulation in these guidelines generally refers to therapeutic vitamin K antagonist therapy. And that was studied in a trial called the WAVE trial for MACE reduction. It was not beneficial and actually had intolerable bleeding. And in the patients in the Dutch BOA trial for graft patency, that was a neutral trial as well. There was a signal, as you can see in the European, for bypass. So we don't have a lot of data to go on here, and we have a lot of information now that extends beyond the guidelines, and that's the COMPASS and Voyager trials on the right side of the slide. And here you can see that COMPASS was published in 2017. This was a chronic PAD population. And there you can see patients that had real deal disease and generally polyvascular disease were enrolled, and there was a reduction, almost a 30% reduction in MACE, and a 40 or 50% reduction in major adverse limb events, including a significant reduction in amputation. Now, the Voyager PAD trial is a complementary trial, but it really extended these observations to exactly the patient that we're talking about. It was the post-revascularization setting, either endovascular or surgical. And it also allowed patients to have a background of clopidogrel, just as we saw in the current patient. So let's zoom in a little bit to the Voyager data, and you can see on this slide very nicely in the rapid resource, you have in the top box that all patients were randomized to rivaroxaban or placebo, and on a background of aspirin or clopidogrel About half of the patients got clopidogrel. Only about a third had coronary disease, about 40% had diabetes. And there was about 2/3 endo patients, about a third surgical, and there were a large proportion of patients, just like the one that we're talking about here, that came in with critical limb threatening ischemia, very large cohort. And here are the results. You can see that, first of all, if you look at the aspirin alone arm for the primary outcome of major adverse events of the heart, limb, or brain, the event rate was 20%. And this really is an aspirin alone, because about half of these patients and more in the endo arm all got clopidogrel as well. It was still 1 in 5, in spite of best medical therapy, had an irreversible harm event of at least one. And you can see that there was a significant reduction with rivaroxaban here, with a number needed to treat of around 39. And you can see the consistency for all of the different endpoints here laid out on the slide. Now, there was a bleeding hazard, as you can see, hazard ratio of 1.43 for TIMI major bleeding, about the same for ISTH major bleeding, but no excess in intracranial hemorrhage or fatal bleeding. So Voyager really speaks to the patient profile. And I think we know, regardless of what you use, whether it's aspirin or aspirin and clopidogrel, that there's a very high risk and that dual pathway inhibition therapy is efficacious and that there's a net benefit.
Great. So let's continue our case. Our lady it's recommended that we add the addition of rivaroxaban 2.5 milligrams twice daily in addition to low-dose aspirin. The surgical team prefers that this patient be continued on clopidogrel for 3 months. Can she be on dual inhibition therapy in addition to other antiplatelet agents? I'm going to ask both questions, but this one I'm going to ask Marc to respond to. The second question is, what considerations for bleeding risk should be evaluated for if the patient is considered for dual inhibition therapy in addition to clopidogrel? And Marc, when you're done answering yours, I'll ask Bishoy to answer this question.
Yeah, well, it's a great question. Many practitioners after endovascular intervention still favor to use a combination of aspirin and clopidogrel because that's just been what we've done in the absence of clear guidance. And I think that's reasonable. That doesn't mean you shouldn't start rivaroxaban. Again, in the Voyager trial, it started at the same time, and there was no treatment interaction, meaning the benefit of rivaroxaban is the same on top of clopidogrel, as is the safety. But here's some do, don'ts, considers, and cautions. First, in patients that do end up on triple therapy, so aspirin, low-dose rivaroxaban, and clopidogrel, define the duration and communicate it a stop date, because you don't want people to be on this for a very long period of time, meaning years and years, of course, because the bleeding risk will go up, and there's really no benefit to long-term clopidogrel here. Also consider the intended duration of the dual pathway. It's as we think of Voyager, there's the post-procedural patient, but then they really translate into a chronic PAD patient, just like Compass. So generally, you want to define this as a long-term therapy. And I would say, although the team here is considering 3 months, you might say maybe a month would be good enough. And that's what the trials suggest, at least from a Voyager perspective, that may be safer to shorten the duration. And in terms of cautions, be cautioned when there are higher doses of aspirin. So this was low dose aspirin. There doesn't appear to be any benefit of higher doses of aspirin. And we don't know a lot about more potent P2Y12 inhibitors and safety. So ticagrelor and prasugrel have not been studied in large trials in PAD post-procedurally in terms of the bleeding risk. And so certainly in combining these therapies, you want to be cautious. Thank you.
I appreciate it, Marc. With regards to bleeding and assessing bleeding, the important thing here is to understand and to recognize we don't have a formal risk scoring to quantify bleed risk in PAD patients. So what we've presented in the rapid resource in the assess bleed risk table are actually taken from the exclusion criteria from either one or both of the Compass and Voyager trials. So the first thing up there that you'll see is the need for dual antiplatelet therapy or other non-aspirin antiplatelet therapy as well. In the Voyager, specifically, as Marc alluded to, they did allow for dual antiplatelet therapy for preferably 30 to 60 days, but up to 6 months post-op, but no other oral antiplatelet therapy beyond aspirin or clopidogrel due to the increased risk of bleeding associated with the other oral antiplatelets above the others. Other ones to look at and to consider would be a history of hemorrhagic stroke. Obviously, the history of a particular event would confer the highest risk for a possible recurrence. Other ones would be a significant history of significant bleed. And those were essentially defined as either a medical history or active clinically significant bleeding or lesions, or conditions within the last 6 months prior to randomization that would confer a high risk of major bleeding in the patient. And those are things included in those would be any type of current medically confirmed GI ulceration, the presence of malignant neoplasms that are associated with a high risk of bleeding, esophageal varices or vascular aneurysms of the large arteries. Other ones that were also included were current or recent brain or spinal injury, or any type of intracerebral vascular abnormalities. And lastly on here are the coagulopathies or bleeding disorders. And in the trial exclusion criteria, those were actually defined as being related to any known hepatic disease that the patient might have.
Okay, second case is a 73-year-old man with known PAD who presents to clinic with worsening claudication. His past medical history is notable for diabetes and CAD. He also has a remote history greater than a year ago of peptic ulcer disease that was treated with injection and PPI therapy, and on follow-up EGD, this had resolved. Also notably, he is not currently on PPI therapy. His labs, normal creatinine, normal CBC with platelets, most recent ABIs demonstrated ratios of 0.65 on the right, 0.62 on the left. He has not had any previous revascularization procedures for his lower extremity PAD. Next slide. Current medications include low-dose aspirin, high-dose atorvastatin, lisinopril 20 milligrams, metformin 500 milligrams twice daily. Would this patient benefit from a dual inhibition therapy approach? And I'm going to reach out to my colleague and friend, Jeff Barnes, to answer this question.
Hey, thanks, Eva, so much. You know, this is a really great opportunity to talk about the patient with chronic peripheral artery disease. Marc and Bishoy walked you through a patient who had just been revascularized, and now we're going to focus on sort of that patient who has chronic disease. And as always, let's look to what the guidelines tell us, and then we'll see what additional data we have. So again, we go to our rapid resource, and we focus here on the guidelines. And first, you'll see here from the AHA ACC guidelines from 2016, they say that anticoagulation should not be used to reduce the risk of cardiovascular ischemic events. But as Marc really nicely pointed out, what they're talking about here is therapeutic, full dose anticoagulation. Primarily, we're talking about warfarin with an INR of 2 to 3. I'll also comment that we have to remember these guidelines were written in 2016 and 2017. And this was really before the COMPASS study and the Voyager PAD studies were published. And so this does not take into account the data from either of those two important trials. Now, the ESC PAD guideline does say that long-term single antiplatelet therapy is recommended for these symptomatic PAD patients, and that's clearly the case that Eva has presented for us. But of course, the question is there anything more we can do? What else have we learned since these guidelines have come forward? And I think that we're gonna see that as we go here to the next slide, that there's probably something beyond single antiplatelet therapy that we could offer this patient. So let's focus in on the COMPASS trial and let's sort of see what data we have here. Again, structured the exact same way as what Marc walked you through with the Voyager PAD study. In this rapid resource, we have a summary of the COMPASS clinical trial. This was a trial of patients with stable symptomatic peripheral artery disease. So largely patients who had intermittent claudication. And this was usually somebody who had symptoms and they had some objective evidence that this was because of peripheral artery disease. Maybe it was abnormal ABIs, as we heard about earlier. Maybe it was some sort of a imaging test. Maybe they previously had some sort of an intervention, but we knew that this was peripheral artery disease. 2/3 of these patients also had coronary disease, and just shy of a half of them had diabetes. So this really describes the kind of patient we're hearing about and also nicely matches what you heard from Henry in those introductory slides. This is a very common patient that we would see. Now, they excluded anyone from this study who needed dual antiplatelet therapy or other non-aspirin therapies. They also excluded patients who were at high risk of bleeding or needed therapeutic anticoagulation for some other reason, as well as a few other exclusion criteria that you can see there. But let's focus in on the results. So as we saw before, the rivaroxaban plus aspirin group is in the first column. The aspirin alone group is in the second column, and then the hazard ratio is in the third. And for that primary outcome of cardiovascular death, stroke, or non-fatal MI, you can see there was a significant reduction from 7% in the aspirin alone group down to 5% in the combination rivaroxaban plus aspirin group. That was a hazard ratio of 0.72, or roughly a 25% risk reduction. And you can see, again, similar types of outcomes when you look at other, similar types of reductions when you look at other outcomes. The one I want to highlight here is that MALE. MALE stands for major adverse limb events. Think of this as like heart attacks, but of the limb. We're talking about people needing amputations, people needing urgent revascularization because of some sort of a ischemic event. The overall event rates, thankfully, are pretty low. We're looking at 2% or 1%. But shockingly here, we saw a 50% reduction in these events when people were treated with rivaroxaban plus aspirin. And as Henry talked about early on, it's probably because we're attacking this from two different mechanistic pathways. And so that's why we see a little bit of benefit there. Now, just like we saw with the Voyager PAD study, there is some increased bleeding when you use both of these mechanisms. So you're using the low-dose rivaroxaban plus aspirin. That had a 3% major bleeding rate as compared to 2% with the aspirin alone group. On the right side of the screen is really, I think, an important piece. How can we figure out what patients are most likely to benefit from this strategy and which patients may be more likely to get harm? And if you look at both MACE or male features, there was much better risk reduction. The absolute risk reduction was much greater if the patients had high risk features. And we'll talk about what that means in a minute. If they didn't have any of the high risk features, they had a much smaller absolute risk reduction, meaning the number needed to treat was a lot larger. The same thing is true for major bleeding. If you have high risk bleeding features, the absolute risk increase was higher than if you did not have those high risk features. So we can look at some of those features to figure out who may be the right person to get benefit, but maybe minimize the risk. Let's go to the next slide.
So you recommend dual inhibition therapy with rivaroxaban 2.5 milligrams twice daily and low-dose aspirin. Are there certain comorbidities that you would think about more to decide who with symptomatic PAD may benefit from dual inhibition therapy? This I'm going to ask Jeff to answer. And then how would you consider bleeding risk in this patient given a remote history of peptic ulcer disease? And that one's for Bishoy.
Yeah, Eva, I think these are two great questions. And I think we can go back to that same part of the rapid resource to look for this. So table 2 on the left-hand side of the screen helps us think about what some of the high-risk clinical comorbidities are, sort of the patient level features, and then what are some of the high-risk limb presenting features, some of the things we really need to think about the limb itself. Patients with renal dysfunction are at higher risk for having adverse events. And this is renal dysfunction meaning an eGFR of less than 60. So I know we're all anticoagulation folks. We start to get nervous when that creatinine clearance gets down below 15 or 30. We're talking about a much higher threshold here. So an eGFR of less than 60. Patients who have heart failure or diabetes are at higher risk for having complications. And importantly, patients with polyvascular disease, meaning we know they have atherosclerosis in 2 or more beds. So maybe it's the legs and the heart. So they have peripheral and coronary artery disease. Maybe it's the legs and the arteries of the neck, the carotid artery disease, or even all 3 together. When you look at the limb itself, if they previously had an amputation, that's a very high risk patient. They've previously been revascularized in the leg. If they're telling you about rest pain or anything else to suggest they have critical limb ischemia, those are certainly high-risk patients, more likely to have adverse events, more likely to get benefit from getting dual inhibition pathway treatment with Riva and aspirin.
All right, so with regards to peptic ulcer disease in this particular patient, just want to go back and recall the exclusion criteria in the Voyager specifically for GI ulcerations was any GI ulceration confirmed within the past 6 months prior to randomization. In our particular patient, however, the patient has a remote history of peptic ulcer disease and currently doesn't have any ongoing ulcerations or symptoms. So that being said, in this particular patient, it would be reasonable to pursue the dual inhibition pathway with rivaroxaban and aspirin.
Given this, you recommend taking PPI in addition to his dual inhibition therapy. What other medication factors do we need to consider? Are there significant drug-drug interactions to worry about? And also, what if this patient also has chronic kidney disease? Bishoy, your thoughts?
Yeah, so with regards to using a PPI, there was actually 17,000 patients who were randomized within the COMPASS trial to receive either a placebo or PPI. And those results published a couple years after the COMPASS trial results were published. One important thing to consider was that actually previous peptic ulcer disease patients weren't excluded from the randomization of using a PPI. And it was about 2.5% of patients. Ultimately, while the study didn't show benefit in routine use of PPI in patients who were deemed to be at low risk of GI bleeding, there did appear to be some benefit in patients who had previous peptic ulcer disease, and they apparently showed greater benefit from using PPI. While again, the study wasn't necessarily powered to be conclusive about it, it was more hypothesis generating. Overall, it would be very reasonable and probably should strongly consider using a PPI in this patient due to their history of peptic ulcer disease in the past. With regards to other medication factors, we'll go ahead and look here at the do, don't, consider caution table here. The first thing within the don't, the name of the game here would be to stick to the dosing recommendations. So we are not to avoid using rivaroxaban 2.5 milligrams once a day, or the temptation for some providers to possibly equivocate apixaban 2.5 milligrams BID with rivaroxaban 2.5 milligrams BID. The other thing is, be sure that if you're going to use rivaroxaban, that you do use it with aspirin. Do not use the rivaroxaban BID 2.5 milligrams without the use of aspirin. And also, lastly, we want to be sure that we don't pursue a loading dose or a lead-in dose of rivaroxaban at initiation. Once again, stick with the 2.5 milligrams BID of rivaroxaban plus the aspirin. Moving along to the consider the cost of rivaroxaban to the patient. Obviously, if the patient can benefit from it from a data standpoint, there's really no benefit to the patient if they cannot afford to obtain the medication. So be sure you utilize any type of patient assistance programs or ensure that the patient is able to obtain the rivaroxaban and use accordingly. Also consider the impact of polypharmacy and drug-drug interactions that the patient might have. So these would be things like NSAIDs or drug interactions that might involve PGP or 3A4 induction or inhibition. Also, different things like different over-the-counter herbals would be something to consider as well. So things like turmeric or garlic that would promote bleeding, those are things to look into as well with regards to those specific supplementations. And then lastly, with regards to chronic kidney disease, we would want to basically pursue baseline labs as we would with any DOAC at initiation, and make sure that we obtain those at the onset before we start the medication. And then one thing to consider here is that within the Voyager and COMPASS trials, the renal function was based on eGFR, and patients were excluded if eGFR was less than 15 mLs per minute. Generally, we are used to seeing dosing being adjusted based on creatinine clearance of actual body weight, but in this particular instance, we want to focus on eGFR with make sure it doesn't cross less than 15 mLs per minute.
You receive a phone call from the patient's PCP who tells you the patient now has a new diagnosis of AFib with a CHADS-2 VAS score of 5. How do you counsel the patient and his PCP regarding antithrombotic regimen? Jeff, your thoughts?
Yeah, Eva, this is a really important question and something I think we see a lot. And we have to remember that when we're using rivaroxaban here in this vascular protective dose or this dual inhibition pathway, we're talking about 2.5 milligrams twice a day. That is not the same as the AFib treatment dose or the VTE treatment dose that we're used to using. And so if a patient has AFib, for instance, we need to step up our game and give them full therapeutic anticoagulation. So for most patients with rivaroxaban, that's going to be 20 milligrams once a day. That's going to overrule the use of this dual inhibition pathway. So we'll transition that patient probably to rivaroxaban and consider whether they should be on monotherapy or whether there's a real need for them to be on aspirin in addition. So it's really important that we think about the benefits of dual inhibition pathway, think about other potential indications that they might have for anticoagulation, and make sure we're giving them the right level of treatment based on their various comorbidities and conditions.
So I'm going to, I want to make sure we have plenty of time for questions. And before I do that, I wanted to point out that as a group, when we were developing this rapid resource, we wanted to make sure that the main points in the were easily accessible, that this would be a good guide for the bedside clinician to be able to quickly use. So on the rapid resource itself on page 1 in the lower left is a table 1 that really summarizes therapy. So you can see on the left, single antiplatelet therapy is favored in PAD patients with mild disease or moderate high bleeding risk. An alternative would be favored if these patients had previous peripheral revascularization, a prior stent, or previous limb ischemia. When do you use DAPT with clopidogrel? There's actually limited use in stable PAD, and consider if there's concern for high bleeding risk with concomitant high risk of cardiac events, a recent ACS, recent coronary stent. Additionally, you may consider for a short period after an infrainguinal stent implantation or below the knee bypass with a prosthetic graft. And then finally, when is aspirin and rivaroxaban 2.5 milligrams BID favored? These are in folks that had previous peripheral revascularization, previous ischemic limb events, high risk for amputation or limb ischemia, high risk for coronary events, or a prior carotid artery revascularization or carotid stenosis of greater than 50%. And you kind of want to stay away from this in those very high risk patients, which include high bleeding risk, previous lacunar stroke, severe heart failure, severe renal disease, or use of strong inducers or inhibitors of the CYP3A4 or the PGP. And also cost concern should be factored into this as well. Next slide. And similarly, the key points are also on the first page of the rapid resource. So I know we presented a lot of data today, and I thought the panelists did a great job in using the evidence to support how each of our complex patients were treated. And when you think about this, for me, I'm always thinking key points when I'm seeing patients in clinic. So first of all, studies were conducted on symptomatic PAD patients. So all asymptomatic patients were excluded. The dual pathway studied in clinical trials, as Bishoy pointed out, was rivaroxaban 2.5 milligrams twice daily and low dose aspirin. So that was the combination. High risk groups accrue more benefit with rivaroxaban and aspirin as shown in the 2 trials. However, low risk patients still may benefit as well. The Voyager PAD found benefit in the post-revascularization setting with dual inhibition therapy in both endovascular and surgical settings. High risk bleeding included prior intracranial hemorrhage, prior major bleeding, need for therapeutic anticoagulation, bleeding diathesis, known GI ulcer, and there's a nice bleeding risk table, as you can see on the resource. Bleeding risk from both COMPASS and Voyager did not show increase in fatal bleeding or intracranial bleeding, and bleeding risk is front-loaded in the first year. That's what came out of both of these trials. Therapeutic anticoagulation dosing should be considered in acute limb ischemia. Otherwise, dual inhibition therapy dosing is 1/4 the systemic anticoagulation dose of rivaroxaban. And I think Bishoy pointed that out as well. So the analysis from COMPASS trials showed the majority of bleeding was gastrointestinal. And I think that concludes the presentations. And I'm going to start us out As I reviewed the questions before, and I want everybody to have a chance to send their questions in. So I'm going to start out with the first one because there were two questions about this. Do you anticipate changes in treatment guidelines as a result of these two trials? So I'm gonna just send that out there to the panelists.
Well, Eva, I think that's a really good question. And as was pointed out during the talk, the most recent guidelines were written in 2016 on the North American side, 2017 in Europe. And there's a new guideline panel that I know has recently formed and is looking at updating the ACC/AHA PAD guidelines. And so I would expect that that group is going to be reviewing both of these trials and thinking about how they fit into some updated recommendations. So probably in the next year or two, we'll be hearing more, at least here on the North American side of things.
Great. And I have another question, and then I'm going to let somebody else go, but there were two questions about special patient populations. So one had to do with older patients and the other one with obese patients. So would anyone like to address those two?
So I can address the obesity subgroup. Actually, coincidentally, there was a trial published in JACC just last week that was a secondary analysis of COMPASS. And they looked at patients across all body weight categories. And what they found was that rivaroxaban and the aspirin combination the efficacy was consistent across both all body weight categories. And they spanned it from BMIs less than 18 all the way to BMIs greater than 40. And they also found there was no difference in terms of the rates of major bleeding. But you can actually find that in the literature update, shameless plug here on that. So if you can go back to the Centers of Excellence website and the literature update, it will be there for a link if you need to access that.
And I can add to that just in terms of the elderly. You mentioned that was a predefined subgroup in Voyager, dichotomized at 75 years of age, and the benefit actually in the elderly was quite robust, and the safety was consistent. And so, that was quite reassuring to see an elderly, vulnerable population. There's a lot of frailty in the PAD population, concomitant coronary, kidney disease, other issues, but efficacy and safety look quite consistent, and net benefit in the elderly as well.
Marc, I want to ask you a question. This came up from some of the folks. You obviously were so intimately involved with Voyager PAD, and this idea of using this very low dose of rivaroxaban in a patient who recently had a procedure, whereas a lot of the proceduralists, be them surgeons or interventionalists, I mean, they're used to using dual antiplatelet therapy. Sometimes they use full therapeutic anticoagulation. How did they handle using this sort of new dosing strategy, and what was their reaction to it? Did they sort of combine things? How did they sort of adapt this new Riva 2.5 plus aspirin to their current practice, and what was that experience like?
Well, it's a great question. I mean, this was a pragmatic trial in many ways, in that it was really broadly inclusive. There's no enrichment for risk, and we had to allow a variety of background therapies, to your point. Now, we did not include vitamin K antagonists or therapeutic anticoagulation because that would have posed a safety risk, but we did allow the use of clopidogrel, and the use of clopidogrel could be as long as 6 months or even longer if you had an indication. And it was exactly to that point, Jeff, that you have to accommodate existing treatment patterns. But I think that enabled us to conduct the trial. I do think that those therapies reflect a bit of a data-free zone where people have been recognizing thrombotic risk and trying to use things that kind of make sense based on experience in the coronary bed or in other conditions, even though the trial sort of suggest there may not be clear benefit there. And I think what was notable in Voyager is that the efficacy and safety of Riva were totally consistent, even in absolute terms, whether or not you use, for example, DAPT with clopidogrel. The absolute risk reductions and the net benefit were consistent. And it just shows you that you're accomplishing something different other than P2Y12 inhibition by targeting thrombin.
And following up to that, thinking especially about that post-revascularization patient, where maybe we're used to using dual antiplatelet therapy, is there any data out of Voyager that helps us think about how long they should be on dual antiplatelet therapy if we're going to use the riva aspirin? I mean, this triple therapy, should we use it just for a week, a month, 6 months? I mean, how long should we think about using it if we're committed to a little bit of dual antiplatelet?
Yeah, great question. I think the notion for the use of dual antiplatelet therapy is really to protect the limb artery that you've intervened on, right? To prevent thrombotic complications of the procedure. It's worth noting that the risk of ALI after endo was similar with or without clopidogrel. Of course, that wasn't randomized, but it didn't appear there was a huge effect there. And the benefit of riva was apparent within the first week on top of clopi. So I'd say clopidogrel is not enough to prevent the thrombotic occlusion of your stents. There was about a halving of that risk when you add riva on top of it. Now, in terms of efficacy, it's hard to comment on a duration. What was clear though was safety, and that for people that continued on aspirin and clopidogrel for more than a month, along with rivaroxaban, we started to see an excess bleeding risk, and that long-term DAPT, and as part of triple therapy, didn't appear to be good for bleeding. And so what we took away from that, and there's a paper in circulation, is that if you're going to use DAPT, that a month appeared to be sort of optimal in terms of the balance of efficacy and safety, and that you really wouldn't want to do a longer duration unless you had a good reason.
Henry, I want to ask you a question. One of the things that's come up is balancing the benefit against the risk. And especially if we think maybe about the COMPASS trial. So a patient with chronic PAD or even chronic atherosclerotic disease, because COMPASS was a larger trial than just PAD. Some people may look at that data and say that the reduction in thrombotic events or cardiovascular events or limb events is somewhat similar to the increase in the bleeding risk on the overall total trial population. Are there ways that you can sort of identify patients who maybe get a little bit more benefit or maybe have less harm, that you could target some of this? Or is this something you're using across the board on any patient with PAD? How do you think about that?
Yeah, it's a great question. I think that's one of the most important questions and one of the questions most people have with regards to balancing the sort of risk benefit for these patients. I think in my practice, certainly it always sort of comes as a case by case basis. I feel like it's difficult to generalize across the board. So in the example that we sort of presented with someone that had a very remote, greater than 1 year history of peptic ulcer disease, right? We would say the bleeding risk is otherwise low, but as you sort of mentioned, some of these other high risk features, for example, someone who's had intracranial hemorrhage in the last year, right? Or having more vascular tumors or malignancy that we think is more prone to bleeding, for example, melanoma, right? We would be, I think, more cautious to consider using dual inhibition therapy in these sorts of patients. I think it also comes down to sort of thinking longer term, because that's really where we're considering the benefit for using low-dose rivaroxaban and low-dose aspirin in combination. And so to say, will this patient long-term derive the benefit, and is that sufficiently weighed against their bleeding risk? I think it's a little hard to say that as a blanket statement that we have any sort of calculator or scoring that balances these at this time. I think it's certainly an area that's very interesting that we may be able to study further. But to say that I think it still does sort of come as a case-by-case basis, at least in my practice.
Yeah, and Marc, let me just ask you to follow up on that. I know there have been a couple papers trying to identify which patients get the most benefit from this strategy. Are there any sort of ones that really stick out to you, or easy ways to remember who to think about using this dual inhibition strategy in?
Yeah, that's a great question, Jeff. So there's a great paper by Sonia Anand and Jack, which looks at people that had high-risk features from the COMPASS trial. That's really looking at MACE. So people with diabetes, polyvascular disease, other risk factors like heart failure, they had a really big net benefit. And so, you'd really want to think about it there, whereas the relative risk reduction was the same in those without those conditions, but the absolute benefit was a bit lesser. So I think that's a good reference. From the Voyager perspective, which is a bit of a different calculus, to me, it's quite simple. Either patients that have polyvascular disease, so PAD and CAD, there was a very clear, robust benefit and net benefit. And then I think those patients who have higher limb risk, so those patients who had critical limb ischemia, multiple prior revascularizations, prior amputation, all those sort of things, longer lesion length, as you're thinking about the limb risk, they had even greater absolute benefits. So overall, a number needed to treat of 39 is pretty good, but those subpopulations had even greater benefit.
Yeah, so for me, a real take home here is that this dual inhibition strategy is not for everyone, but we can identify those patients most likely to benefit, maybe try and minimize some harm, and think about using this in the appropriate patient to really offer some help. Bishoy, I want to ask you a really sort of practical question that's come through from the audience. When a patient comes in on this really low dose of rivaroxaban, we know that's not the same as being on treatment dose anticoagulation. But how do we deal about things? Let's say they're hospitalized for some other medical condition, and we would normally give them VTE prophylaxis. Does this count? Do they still need VTE prophylaxis? How do we handle some of those issues that come up with this really low rivaroxaban dose? I think you're muted there.
Yeah, great question. I was actually responding back to one of the participants on that. So, you know, in terms of VTE prophylaxis, if a patient has been identified needing VTE prophylaxis, then rivaroxaban 2.5 milligrams BID won't suffice. At least we don't have data to suggest it would suffice. So it wouldn't be something that I would personally approach using. So very similar to other cases, what we would do is just have the patient use the prophylactic dose of whatever anticoagulant they're going to use, whether that be rivaroxaban 10 milligrams or prophy doses of LMWH. And then once they're discharged and they're deemed out of that risk for VTE, we'll go ahead and resume again the 2.5 milligrams BID plus aspirin once they're discharged.
Okay, well, thank you so much to all of our speakers for walking through these cases and demonstrating the usefulness of our new rapid resource. Thank you to Dr. Henry Hahn for your excellent presentation, to Eva Kline-Rogers for presenting the cases, and to Drs. Geoff Barnes, Marc Bonaca, and Bishoy Ragheb for the great explanations and panel discussion. As we mentioned, this is one of a dozen new rapid resources we have created, so please visit our Centers of Excellence Resource Center to see the other topics available. Once again, you can claim credit for this webinar at this link, which is also on the webinar page of our website. Our March webinar is going to be very special. We are partnering with the American Heart Association and ASHP to discuss AHA's new call to action, Structural Racism as a Fundamental Driver of Health Disparities. We have two of the authors of the paper along with other guest speakers for a panel discussion. The AC Forum has committed to increasing diversity in our leadership, membership, and programming, and we hope everyone will join us as we work towards meaningful change and a reduction in health inequities. The AC Forum is hosting our next virtual boot camp on April 15th and 16th. This is one of our most popular programs, and we have an extended phenomenal faculty for this boot camp. Registration is now open on our website. Lastly, we are very excited to celebrate the AC Forum's 30th anniversary. Join us the night before boot camp on April 14th for a special celebration, and stay tuned to learn more. As usual, this webinar has been recorded, and the recording and the slide deck will be posted on the AC Forum website in a few days. I'd like to thank Janssen for their sponsorship of this program. Thank you again for joining us, and have a nice day.